I'm going to start with just a couple of questions, and then we'll open up to the audience. To Gail and her team. Gail, you spoke this morning about the fact that these changes align with what is going on elsewhere in the Medicare system, that pay for performance and public reporting have become now generally accepted. Do you think that argument will be helpful with Congress and with the others that have to act on this to do the enabling legislation?
I think it will be helpful, but I don't know whether it will be helpful enough. What is probably the largest issue to overcome is that historically the distribution of funds has been very concentrated in certain geographic areas. I have found it surprising in the 20 years roughly since I ran Medicare and then chaired the Physician Payment Review Commission and Medicare Payment Advisory Commission, that so many parts of the country which face many similar needs have willingly tolerated this historically peculiar distribution of funds. I don't think selling the notion that these changes are consistent with moving to performance-based payment, which Congress is aware of. They tried very hard in the physician payment reforms that were proposed to move physician payment precisely in these directions with transitions over time. So much of this should resonate. I think the willingness of Congress to redistribute funds, which is always more challenging than distributing new funds, will in large part depend on whether the institutions that are trying to implement new programs and the institutions that receive existing funds recognize there are innovations they could also propose to allow them to capture the redistributed money will be critical as to whether or not Congress is willing to take this fight on.
So as a follow-up question, do you think that the assurance, first of all, do you think Congress will buy the fact that the pot should stay the same? And on the other side, do you think that addressing the academic community, that buying into this plan will be a way of keeping the pot the same as the alternate to all the other proposals that have been out there that shrink the pot will work?
We hope that we have chosen a reasonable, rational, defensible middle ground between many stakeholders and supporters that I'm sure will be disappointed that we are not recommending increased funding for which there was no strong support on our committee, with those that have recommended savings by reducing the amount of indirect medical education funding that is currently contained in Medicare, recognizing that the delivery system we dearly hope is in the process of change. I think most of us, I think all of us hope it's in the process of change, and many of us see signs that it is changing, that at least in the short term, it is so important to use these funds which exist in the Medicare program and which the report yesterday suggests are not immediately under threat in terms of being exhausted, to use these funds differently so as to produce the workforce that will be critical to building healthcare teams and other changes for the 21st century. So we deliberately attempted to straddle this fence. We thought telling Congress to spend more money now, not only didn't we have the rationale for doing that, but the politics seemed challenging. But we didn't want to give up the funding that is currently scheduled because the need to train physicians differently from the way they've been training seems so critical to getting to where we want to go.
Great. Yeah. So for Malcolm, Ed at the end of his comments, I thought made a very good case of why academic medical centers could see positive things in this and how it could speak to issues that are important. Could you talk a little from your experience working in a couple of major academic medical centers, how you think this will be received, and what are the opportunities for getting people to buy into these kind of changes?
I think it provides an opportunity and a focus for discussion. It does not guarantee in any way buy-in. And I think those who have benefited most from the current dysfunctional system will find it harder to buy into something that changes their life significantly. On the other hand, those who have suffered the consequences of the current dysfunctional system will buy in more easily. The concern is, in my mind, that we don't polarize those two communities. And I think the report has tried, as Gail has said, to bridge the extremes. What we don't need is extremism in change. We need phased-in, thoughtful, measured change. But I think that there's a very real opportunity that, or the very real possibility that there'll be more heat than light around the winners and the losers. So that whatever we can do as a group here and listening in the virtual environment, and whatever the follow-up discussions that will flow inevitably from this report can do to explicitly identify mechanisms to bring those two extremes together, as the report has already begun to do, but I think there needs to be more work in that regard.
Mm-hmm.
So to me, the big issue is, what is the follow-up to this? Not just the follow-up from the congressional perspective. That's sort of obvious, and Gail has already addressed that in the aggregate. But what is the follow-up for the stakeholders, this dizzying array of stakeholders that we have? How to bring them towards the middle rather than one of the two extremes, I think, is the critical issue.
Great, that's very helpful. So now to begin the dialogue that we hope is going to go on for some time to come, a responsible, constructive dialogue about how we can move forward. Let me just start by enunciating what I think are the principles that drive this report before we get down to the details. The principles are that we should have a system that has accountability, because that is, in fact, what we expect. Not only when we're spending public money, but we're spending private money, having come from private sector institutions. And that accountability includes performance measurement and reporting, and that should be expected. So that's a principle. Second principle is that the purpose of education, of graduate medical education, but any education system, whether publicly supported or privately supported, is to meet the needs of the public. And that's particularly true of healthcare, and that was enunciated by some. So we should be measuring this against meeting the public needs. The third principle is that we must promote innovation. No matter how good something once was, it doesn't remain good without innovating. And we have lots of reasons to say that we need more innovation now with all the changes that we've talked about. The fourth is that for enterprises to succeed as educational institutions, caregiving institutions, there needs to be some sense of stability. The rules can't change every month or every year, and there needs to be a stable flow of funding with planned growth or change. And the fifth principle is that there needs to be alignment between our educational enterprise and our delivery enterprise. I actually think it's important to think about those. Those are what I think are the guiding principles. And we could measure the report not so much against whether it got all the details right, but whether it addressed to was true to those important principles going forward. And I think it does address those principles going forward. We can work on the details. So now let's open it up for questions, and I hope we'll have a good, healthy dialogue. There are people on the webcast as well, so yes, please come to the mic, please. There's two mics. There's one over here on the right by the post. There's one in the middle. Please go to the mic, identify yourself, and identify who you're addressing your question to. Yep, go ahead.
I did medical school at George Washington here, and I've been in New York and also worked in Utah. I don't treat anybody but Medicare and Medicaid patients in my ER.
So let me be clear. When people are talking about accountability in the report, sure, it's not about treating more Medicare and Medicaid patients. Mm-hmm. It's about accountability for how the GME dollars specifically, sure, are being used and distributed. That's the accountability.
I just have two quick points. Instead of just hearing these ideas, we need innovation with these things, I'd like to hear specifics. I know you said you shied away from making those. I don't think you'll have a problem with professors choosing to follow evidence-based protocols, but there needs to be some evidence for those protocols to be followed.
Well, that's what we hope that this report will trigger exactly that discussion among professionals.
Are there specifics in there, or does it say we need these things?
It sets up a mechanism to make those happen. It is not prescriptive.
A mechanism under two new agencies. I mean, I can't help but be a little skeptical. Well, the other point I just wanted to mention is last year we had a situation where 500 medical students graduated medical school and didn't have a residency spot to go to. Dr. Salzberg's very eloquent, and I understand he has a phenomenal background in population medicine, but he's a lone voice in saying that more spots aren't needed. In a residency position where I am, we already have utilized some of these situations that he's recommended. We work with PAs and MPs. We have a pharmacist that works in our ER. We do everything we can to be efficient. But we still need more spots, particularly as states are increasing their numbers.
You made your point. We're going to get a couple of responses and move on. Thank you very much. Gail and then Ed are going to make a response to that. And
first, you should look at the report to see that there are examples of the kind of innovations that we think discussed in the chapters. George is correct. We are not prescriptive in saying these are the innovations that we want to see funded by the Transformation Fund, but these are the types of innovations, some of which we had mentioned this morning and this afternoon. The second thing is Utah has had some very interesting activities where they attempted to bring through, I think it was the state, but they attempted to bring various participants in training together into a regional format, which was funded for a while and then fell apart. It's precisely one of the models that we thought was very intriguing, that we would like to have the Transformation Fund, that some of the kinds of innovations. The third is there is a distinction between the generation of new residence slots and what Medicare as a public program should be funding. What we have commented on is that there is and continues to be a generation of new residence slots, frequently in super specialties or specialties, because that's what teaching hospitals have frequently, or other sponsoring institutions, have found desirable. That occurs at the discretion of the accrediting organizations. What we are saying is that when it comes to the use of public funds, like Medicare, those should be targeted in order to meet public needs, and that's a very different thing. So we need to distinguish this regulated, unregulated. We are not recommending anything that would prevent the additional formation of resident slots through the accrediting organizations, which we want to encourage to work together, but otherwise want to wish them well in doing their appropriate activities. Our focus is how to better target the use of public funds in a way that meets public needs, which several of my colleagues here have commented on.
Ed, do you want to speak?
I just want to briefly speak to the question about the 500 or so U.S. medical school graduates who didn't get into the residency this year. And I expanded on this in a column in the Health Affairs blog in March that goes into more detail. But the reality is that there are still far, far more residency positions through the NRMP in America than there are U.S. medical school graduates, and actually more than U.S. medical and osteopathic combined. And the ratio of available slots to graduates is as great as it's ever been. There are issues about advice to and recommendations to medical students. I do take it as a very, very serious issue. We should be very concerned about any medical student who goes through medical school or osteopathic school and doesn't get a position. The answer, however, isn't adding more GME slots. We still have room for 3,000 or 4,000 or 5,000. This year, 6,500 foreign medical school graduates. So there's plenty of slack in the system for the U.S. graduates, and that's somewhat of a different issue than the question of whether we need more slots overall. As I pointed out in that column, right now, if you added more GME slots, the main beneficiary are going to be foreign medical school graduates, and some of us for years have been trying to rebalance so that we are not so dependent on foreign medical school graduates. So it's several issues involved here, but again, my feeling is that there is plenty of room for U.S. medical school graduates in GME, and there will be plenty of room for at least the next decade. And I guess I would just add one last thought. I do get concerned when U.S. medical students are sort of used to lobby for more GME slots. The fact is, GME slots have been growing at 1% per year. That's new GME slots. That's not subspecialty slots. There are plenty of room, and I think it's inappropriate to try and scare medical students in order to raise public support for more GME slots.
So, we need.
Happy to talk to you later.
Yeah. So why don't you two talk offline, okay? Thank you very much.
Thank you. Hank Chowdhury, President of the Federation of State Medical Boards. I appreciate Dr. Powell making a distinction between the report calling for changes in the governance of GME financing as opposed to GME itself. That said, there are a great deal of innovations going on across the entire continuum of medical education. Without getting into the details, and I haven't seen the report, how do you envision some of the private and public partnerships and discussions that clearly your report is calling for to get us to a performance-based system for GME?
So thank you, Hank, and the committee was well aware of the efforts of the osteopathic and allopathic communities, the credentialing and the licensure communities, which have moved to maintenance of certification and maintenance of licensure, and working in conjunction with the GME accreditation agencies have started, as was mentioned, to build a very robust outcomes-based educational system that crosses the continuum. But I think that we do, and we did try to emphasize in the report, which I think you'll see as you read it, that we hope that the Policy Council will serve as a convening group to bring together the governance agencies that govern graduate medical education, not the financing of graduate medical education, to the table with the Financing Council to talk about new programs and new opportunities. And that convening function is a very important function that we note in the report for the Policy Council.
May I make just
Yes,
one quick
sure.
point related to that? The other important function in my mind of the policy and the operations units in HHS are to bring current federal operating units into some level of coordination. I can assure you that at the moment there is considerable dysfunction between those agencies that support financially residency training. So let alone public-private partnerships, which are clearly needed, there needs to be much stronger coordination within the federal government. And that doesn't even address the state systems.
Yes, Paul.
Thank you. I especially liked your...
Identify.
Oh, is it on?
Yes.
Yeah.
Identify yourself.
I'm Paul Rocky. I'm a scholar in residence at the Accreditation Council for Graduate Medical Education. And George, I really liked your 5 guiding principles. And my question relates to the 5th principle, which is, if I could paraphrase, was to align our educational system with our delivery system. And so I compliment the committee on keeping $9 billion in play public dollars paid for by a payroll tax, as Glenn Hackbarth has pointed out many times, and using those dollars as a strong policy lever. But $9 billion pales in comparison to $2.7 trillion, which is in play in our delivery system. And the committee must have considered about how those dollars are being spent and what is going on in that in terms of modeling care. So I know it wasn't the charge of the report, but it's part of that additional work if we're going to align the educational system with the delivery system.
It's 10 billion, not 9 billion. It's, even among friends of billions, it's 9.7 as of last year. The issue about what to do to get a better spending of healthcare dollars in the delivery systems is obviously a very big issue, although many people have noted that we're in an unusual phase of low spending growth. That was what gave us the nice report yesterday by the Social Security trustees that the trust fund is now going to 2030, although the disability fund is in very dire shape. Our focus, and I think our focus appropriately, was to look at the financing of GME, particularly in its use of public dollars, which again is, I don't mean to be a broken record, but what we do with public funding for the training, the graduate training of physicians, is very unusual compared to what we do with public funding in almost any other sphere you can think of, either compared to undergraduate medical education, or for other health professionals, or for engineers or mathematicians or scientists or other areas. And it was within that context that our group thought, how did we get there? Why are we there? If we're there, how can we better use these dollars to produce an educated graduate physician workforce that would be better oriented to meeting the healthcare needs of the patient, of the population, particularly in view of the changing delivery system that we are now experiencing. And it was the leverage that Medicare dollars could provide for change that brought a very disparate group together of saying, this is the reason we should continue using public funds in a more accountable and transparent way. And it's accountable not to the education. The accreditors look at accountability for the education. We were looking at the accountability for spending $15 billion of federal money, $10 billion of which came out of the Medicare system, when it's not obvious why that's happened, or any other major federal funding for this purpose, given its unusual role. So it really was very much in line with several of you have mentioned, which is trying to help in this transformation of getting a workforce that is more attuned to meeting the healthcare needs of the public as we see the changes in the delivery system going on now toward a more value-based, high-performing healthcare system.
Yes.
I'm Dr. Richard Rieselbach, University of Wisconsin Medical School. Getting down to the specifics, the transition fund, will that require legislation or can a CMS ruling be involved in establishing that? And what are your thoughts about utilizing that substantial amount of money in the Center for Innovation, Medicare and Medicaid Innovation in the Affordable Care Act to fund some of that?
The answer is almost everything we've suggested will require legislation because what exists now is in statute, and therefore changing it will require statutory change. We had a number of discussions about whether or not to use the Center for Innovation in CMS as our CMS distribution source site, and did not go that direction because we didn't want to overwhelm what the Innovation Center is now doing, that the distribution of funds has a lot of operational aspects to see that the distribution occurs in a consistent way with the Policy Council's recommendations. But we do think that it would be appropriate for a synergy to occur between the GME Center and the Innovation Center, because when it comes to evaluating pilot, which is only a portion of what that GME Center would be responsible for, the Innovation Center has a more robust research and evaluation component than the GME Center may wish to establish. So we think there are places that CMS could have support. It does occasionally happen within government agencies that you can arrange for this kind of synergistic activity, but that the main functions are separate and ought to be contained within the GME Center.
And just to be clear, it's called the Transformation Fund, right? Not the Transition Fund,
Yeah,
right?
I'm sorry.
I just want
Yes, the Transformation Fund.
trying to get the
Yeah,
language
no.
straight.
Yeah, thank you.
Steve.
Steve Shannon, President of the American Association of Colleges of Osteopathic Medicine. A quick comment on the last issue and then a specific question. One of the problems in implementing the transition in medical education and all education has to do with the ability to provide that education in places where team-based care is being delivered. And so and this sort of silo issue is part of it. So the more that the Innovation Center can drive that and work together with the GME Center, I think that would help. So I just wanted to, that triggered that thought. My specific question, though, is I'm trying to understand still how, Ed mentioned that that this would effectively eliminate the cap and put another mechanism in process. But I'm trying to understand how, if you will, the number of positions in certain specialties would be established or controlled, or exactly how that will happen. I'm assuming the policy center, and maybe through other mechanisms, and I know this is maybe getting too far into the weeds at this point, would be able to make some determination as to certain specialties that may need to be funded in certain areas of the country where others would not, and that the accreditation system for whatever's happening in those institutions would be completely separate, but the funding would then be the, if you will, the governance of the federal funding for GME that would meet the public needs in those areas. Is that the mechanism? So theoretically, under that, you could actually still have expansion of the number of funded GME slots at a lower per resident level.
You will have
Yeah.
that happen because, by definition, we have taken part of what has been a combination of direct and indirect medical education. We are going to a per resident amount for all existing currently funded residents, and then we are moving a portion which we are estimating to start about 10% of the total and maybe work up to as much as 30% of the total if there's enough innovation that is present. That will mean less on a per resident when you combine IME and DME. We very much, again, you mentioned it, but I want to be sure people understand. There are really two different caps or limit types of mechanisms. One is the resident slots that the accreditors choose to accredit. That has been going on, as Ed said, at a rate of about 1% in the last decade alone of growth, at a time when Medicare funding has basically been capped. What we are talking about is what happens to the Medicare-funded slots, and because of all the discussion that the geographic distribution is not obvious relative to the needs, specialty distribution has not always been obvious relative to population needs, that the GMA Policy Council would have its own research going on, suggesting more potentially desirable distributions within the physician workforce, given all of the other healthcare actors potentially at play, and that in the Innovation Center, those groups that wanted to support new programs in priority specialty and geographic areas would apply for funding, and that's what would allow for additional Medicare funding to go to residency programs that are not currently funded either by geography or by specialty. So that's our mechanism to have some of the funding from Medicare go in that direction. It's again trying to better direct the public funding of Medicare to meeting the national needs, not on controlling the generation of new resident slots, which we think ought to remain with the accrediting bodies and to continue, which we assume it will do as it's done in the past.
If I could just follow up really quickly, so the current, envision this is that the funding, the currently GME funded slots will continue to exist, assuming the institutions continue to have those and they continue to be accredited. And new slots may be created based upon this other mechanism. And then the net reimbursement, if you will, per slot will depend upon the total number of slots approved, in a sense, divided by the monies available.
Plus the Children's Hospital,
Yeah, and the THC.
those two groups,
Teaching
the
hospitals.
teaching hospitals. That's a very small, but
Yeah.
we want to sweep
Important,
them in.
important.
Yeah, no, well, especially if you're part of those
And that's
communities.
phase one. Phase two, after we have more information, is the performance-based funding model, where none of the current slots are guaranteed. So the current slots are the starting point. In the future, in order to continue a flow of funds, you have to document that a program is fulfilling the objectives of the funding.
Thanks.
Next.
Fitzhugh Mullen, George Washington University, and a member of the committee. And I just want to express my thanks to George and to the IOM for participation. It was a very good, very collegial, and very instructive 2 years we spent in deliberation. And just a comment that addresses a number of the issues, I think Malcolm particularly in terms of what's at stake, and Ed and others. We've had a GME system as characterized that has grown up over 3 or 4 decades, and particularly the funding aspect and governance to the extent GME Medicare dollars are governed, that is quite entrenched. We heard testimony even from hospital associations that they wouldn't accept changes as if these were God-given arrangements that we have. And in fact, often we who are privileged to get benefits from the government and elsewhere take them to be permanent, fixed, and inexorable. And I think from the GME leadership perspective, from the academic and hospital communities, the notion over the last few years that a variety of important players, including the President's budget and MedPAC and others, have begun to suggest, no, this should be undone or it should be cut back, should give pause for thinking, we have a plan A, what is a plan B? First of all, what is the problem and how would we address it? And if the problem is people who are seeking to cut us back, how do we address those problems structurally, educationally, fiscally? We have not had a plan B emerge. It's a very complicated area, as we all know, a very political area. But what the committee, I think, has succeeded in doing is providing an alternative plan that addresses many of the issues that have beguiled us all in terms of how to move positions around, how to bring new positions into the system, how to use the money more effectively. Yes, I will turn off my phone. And I think that's a huge public service. If folks who like the current system choose to dig in and say, well, you know, we won't consider this, that will be a lost opportunity because clearly the issues that have been characterized as disturbing the public comfort with this are going to keep happening. And at some point, the system will be trimmed or redirected in ways that don't enjoy the benefit of cerebration, of good public discourse. So I think the committee's contribution, in addition to providing a good and workable document, is to encourage public discourse around these issues with now a very cogent plan for an alternative system. And if one or an institution doesn't like that alternative, in what ways do they not, and how might they suggest it be done otherwise? So I would hope that the outcome, and I'm sure many of us on the committee agree, that the outcome of the introduction of the report would be a good, a healthy debate, but in the spirit of not of, you know, kind of give us the old and evermore shall have so, but how do we move ahead? And if this plan is not supportable or not wise in one aspect or another, how would you as an individual, institution, association address that and let the dialogue go forward? I think I speak for many of us in that, but I certainly would hope that those involved in the upcoming debate take a positive attitude and try to go at it in that way.
Thank you, Fitz. Peter, you have some questions from the web?
Yes, George, we have a question from the web. This is from David Dashevsky, who's Research Director at the Committees on Interns and Residents at the Service Employees International Union Healthcare. And David's question is this. The report recommends shifting GME funding directly to sponsoring institutions. Could this potentially cut a crucial funding line for safety net hospitals which train residents but are not program sponsors?
Our estimate is that safety net hospitals will fare much better than they have fared in the past, where the amount of funding has been dependent on Medicare patient days, which they usually have in relatively low supply because of their population. So in the report, we have some estimates of some of the funding shifts that could result, at least initially, until institutions apply for innovation funds from the Transformation Fund. But actually, our estimate is that the safety net hospitals will be better off, not worse off. We think the principle of having the funding going to the sponsoring organization is extremely important in any kind of move toward accountability and transparency. One of the difficulties of figuring out just where exactly the funds flow go to currently is that the sponsoring organizations may be the last place that knows about what exactly happened to the flow of funds.
The question may also be asking, or specifically asking about safety net institutions that are not the GME sponsors. And to the extent that programs are sending residents on rotations to other institutions for specific curricular experiences, we anticipate that will continue, and there'll be a negotiation that will allow for sharing of the funds as needed to support the training in those other settings.
Yes, another question at the mic.
Tom Ricketts, University of North Carolina.
Hi, Tom.
I noticed in scanning the report that you were fairly careful in saying that the payments would be adjusted by a geographic adjustment factor, GAF, much as the Medicare direct care payments are. That would seem to be work against the notion of redistributing geographically the funds, because that tends to favor urban, high cost. You pay them more versus low cost. Now, I know that I was on the panel for geographic adjustment and Medicare payments, and we were very careful to understand that our charge there was to be more accurate, or be as accurate as we could in payment. But we've talked a lot about public interest and redistribution and innovation in payment here, and wondering why you would continue to hold on to the GAF, which is a payment accuracy mechanism, as opposed to a policy instrument.
We think they're really serving two different functions. That having an adjustment recognizing very different cost of living areas can be justified, but if you want to intervene to try to encourage the choice of rural areas, there are a variety of mechanisms that are much more explicit available to you. So I think we don't dwell on that issue. It is commonly a part of the Medicare distribution. To ignore cost of living differences entirely seemed too large a step, and that there are much more deliberate ways to try to encourage rural areas or other areas that have been underserved than to ignore appropriate cost of living adjustments, in our view. But we did not spend an enormous amount of time on that issue, either in terms of what we meant, and the same with regard to the inflation measure. I mean, we cavalierly say adjusted for inflation. At least the economists on the group know that people fight to the death as to which exact inflation adjustment mechanism is most appropriate for whatever you're doing. We just conveniently did not deal with that.
Yes.
So my name is Linda Thomas Hemack. I'm the president and CEO of the Wright Center. We're one of the pioneering teaching health center consortiums. And I'm very intrigued by Dr. Cox's insight about the coordination of federal agencies in the effort for the national solution. So I guess my question, as a teaching health center, frankly, to develop the financial infrastructure for transparency of funding, even though it was a new project for us, so we weren't starting in a bureaucracy that had a complex financial management system. I mean, we were free to innovate. It has been humbling to track expenditures, line items, and to really understand where the investments were going in a multi-dimensional consortium. So I guess my question is, as the recommendation comes out to settle in a CMS policy committee, the governance and oversight, what will be the interaction of that policy committee with the Veterans Affairs, which has a totally different reconciliation process for federal funding of GME, but also with the other agencies of the government that are pushing the new financial integrity processes of the IRS and the super circular audits and how the money gets tracked. So is the position within CMS the place where the federal government can kind of converge their interests? And has there been thought about that?
No, the short answer is no. That's part of the to-be-determined activities. What we have tried to do is to recognize the importance of a coordination, and we have done that in several ways in terms of coordinating the activities of the accreditors with the Policy Council on the distribution. I don't disagree the importance of trying to come to a unified set of principles for the purposes you've alluded to. I think there's recognition about the importance of coming to uniform performance measures when various payers are looking at metrics that are comparable but not identical. So I think it's a fair issue, but it was not a level of information that we chose. We have already had some discussions, just a sidebar, about how what we're recommending might fit into the VA's historical role with regard to supporting graduate medical education. We think there is an ample opportunity because the move of the VA to expand its CBOX, its outpatient areas that have occurred over the last decade or so, and that there is nothing that we are recommending that in and of itself ought to put a stop to the historical relationship between the VA and academic, sponsoring academic positions. And what we are saying should happen to graduate medical education. But it will, of course, need to get worked out, just as how to make sure that there is an ability to reach out to safety net hospitals so that you can pay when you have residents go to those places. Nothing, we don't see anything that we've recommended that would preclude those kind of movements. Mostly what we're doing is try to focus the responsibility and authority with the sponsoring organizations, because we think that's where it should be, as opposed to where it frequently has been.
Thank you very much.
If I may just add a comment to that, because there are really needs for both strategic and operational coordination. And I think the value of the recommendation in the report of both a policy unit, if I can just call it that, and an operations unit that would bring not just federal agencies together, but multiple federal and potentially public entities together, is really a very wise recommendation, because as you know and have alluded to, and as I know all too well, and as Kathleen Klink, who's sitting in front of you, knows all too well, the level of strategic planning across government agencies could be improved, let alone the operational and reporting issues.
Peter, another question from the web.
This question is from Dr. Arnold Iser, professor of medicine at the Drexel University College of Medicine. It's a two-part question. Will highly reimbursed physician specialties such as orthopedics, neurosurgery, and radiology continue to receive the same level of GME support that they have received in the past? Will lower reimbursed specialties, family practice, pediatrics, receive more support than they have?
In phase 1, we've proposed a uniform PRA per resident amount across all specialties. In phase 2, based on pilots and other work from the Transformation Fund, it may differ. There may be different levels of per resident amount or other ways of steering individuals toward more needed specialties.
Thank you. Yes, next. Up to the mic. Hi.
I'm Dr. Janice Orlowski. I'm Interim Chief of Healthcare Affairs at the Association of American Medical Colleges. In a couple of points. In regards to accountability, I think that the committee's report is right on. I think that we have a responsibility to demonstrate that we are wisely using dollars that are given to the GME program. I believe that we already meet accountability standards when we meet accreditation standards. And I think that is something that the public needs to understand, that it's not that the dollars are taken and the programs do what they will. There are accreditation standards and we meet those standards. I think what the panel is saying is that there should be additional standards that we need to meet. And I think the community is welcome for a discussion on how we meet those standards and how we continue to be accountable. In regards to physician workforce, I believe that the majority of reports, as Ed has mentioned, do say that there's going to be a shortage of physicians. I think that there have been some recent reports, and including Ed's own statements, that there may not be a shortage if we have physicians be more efficient. I have to say, I just got back from a faculty meeting where that would probably be something we could discuss further. And if we began to more fully embrace interprofessional team care. And I think that we are along that way. Perhaps it's my years of working as a physician that affect my next statement. But whenever I take a look at a problem, I say, what's the worst and what's the best thing that can happen from this? The worst is if everyone thinks there's not going to be a shortage and we actually fund more, then we're actually going to have more physicians. And so perhaps the wait times at the VA hospitals that are 6 months or 8 months or 10 months, perhaps they'll be 2 weeks. And an oversupply of a couple of thousand physicians is not harmful to the country. If we are wrong, and if we indeed do have a 90,000 or 120,000 physician shortage, as has been estimated by the majority of the reports, we really have a responsibility to plan for that and make plans for the future. And as we work on hoping to improve efficiency and as we work on interprofessional teams, we can adjust that as we go forward. But I think to bury our heads in the sand and say, you know, we now think with hope and with efficiency that we're all going to have enough physicians is not the appropriate way to address a public health issue. The third question, and this is the one that I don't understand as well and really look for some clarification, is the issue that we would actually take Medicare dollars, and as I just heard Gail say, that we would take Medicare dollars, and the panel is very emphatic that we would, those dollars would go to the sponsoring institution. And I believe earlier this morning you said FQHCs and other sponsoring institutions. I'm confused by a recommendation that would say that we would take Medicare dollars right now that are paid on a basis of Medicare health care that is utilized in hospitals and within ambulatory systems, and that we would take that and we would distribute that across a non-Medicare background to FQHCs or other sponsoring institutions. Yet you shied away from an all-payers statement. And so I don't understand the rationale in taking the Medicare dollars and passing them along to other non-Medicare institutions.
Yeah.
We could have said cut the Medicare funding by a third and replace it with all payer dollars. There are really two issues that you've raised. One is, should you add in other dollars, additional dollars? And the second is, how should we fund the current funding represented by Medicare dollars? I will tell you that this commission or committee, unlike other committees, did not have any consensus agreement that additional funding, public-private or public, ought to go into the graduate medical education funding. And given the choice of continuing with Medicare dollars or attempting to combine Medicare dollars with an all-payer system, which those of you who have any political history may know has not been one of the most popular ideas to come up in Washington, seemed without point. That is, there is little more stable and predictable than entitlement dollars. We are concerned that the institutions have as much stability and predictability as possible. Although we recognize in recommending the kind of changes we are doing, we are recommending some disruption, but we think in a thoughtful and careful way. And that we saw no advantage to moving away from Medicare dollars. But I think if you said we didn't, our conclusion was the predictability and stability of Medicare trumped all other options. If you agree to stay with the same total and insist it be a combination of other funding, my guess was that you could have sold that idea. What I'm trying to be sure people understand is this particular committee had no consensus agreement that more public-private or public money ought to be put in the graduate medical education program. It had very strong views that we could better use the existing public money to produce a physician workforce that would be more attuned to meeting the healthcare needs going into a 21st century, much of which is team-based. As an economist, I will say the notion that you can train a couple hundred or 100,000 or 50,000 more physicians and don't think you are going to impact the cost of your system would not fly by many economists. And furthermore, the ability to produce healthcare services in a wide variety of ways with a wide mix of healthcare professionals, some of which we can see when we look to the military and we look to the Veterans Administration. We look to the integrated delivery systems as compared to the modal way healthcare has been delivered in this country, which is in small groups of physicians practicing independently, produces extremely different results, and that's aside from the whole distribution within specialty. So we are not making a statement forevermore that we may not need them. We are saying at this point in time, there is enough difference of opinion about whether or not, with a different delivery system, a different mix of healthcare personnel, we may, in terms of going forward to the next decade or so, which is what we worry about, be able to deliver the needed healthcare services without necessarily thinking we have to engage in people who take 10, 12 years in order to get trained and who cost dearly in terms of opportunity expenses, if nothing else. And so we are not ready to buy in, we're not ready to buy in as a group that it was either clear we were going to be in short supply given what might happen with regard to technology and the development of other healthcare personnel. We certainly didn't regard it as costless.
Question.
Henning Schroeder, University of Minnesota, and currently with the National Science Foundation. I've been trying to understand, by listening carefully to the discussion and by reading the documents, what you mean by indirect medical education funding streams, and I wasn't able to. That may be my fault, so if you could explain that. Thank you.
It is a term of art representing one of the two flows of funds that go to hospitals. And basically what it reflects is the acknowledgement that when all of the variables that might explain the cost associated with providing care for treating an individual with a particular diagnosis are accounted for, there is a residual. And that residual is, on average, systematically higher in teaching institutions, but it's not exactly clear why. Historically, when the DRG payment system was adopted in the 1980s, there was a push to have an added payment go to the hospitals, the teaching hospitals, for caring for individuals with particular diagnoses, even though it wasn't clear exactly why these costs additional costs were occurring. People usually waved their hands and said, ordering more tests, taking care of uninsured individuals, although the uninsured individuals could be entered in and were entered into equation. So it's as hard as you try, when you get done, there is a residual in explaining spending differences for treating Medicare patients with certain diagnoses. That's what the indirect medical education expense is supposed to cover, although it has historically been somewhere up to double the actual empirical amount that anyone explained as being relevant. We have chosen to treat this as a single fund on the basis, among other things, that we are moving away from cost-based reimbursement to value-based reimbursement, and providing higher reimbursement because you spend more is not regarded as favorably as it once was.
Thank you very much.
John?
John Eichelhart, the New England Journal of Medicine. I wanted to go back to a subject really that Steve Shannon raised in part, and really ask for your clarity on this. I take it, at least my reading of the report, places a heavy new responsibility on the accrediting agencies. And I get there in the following fashion. I'm assuming the Innovation Fund will be partial towards supporting efforts to build a stronger primary care capacity in the system. And based on that, if my assumption is correct, the accrediting agency will have to push back from a culture of specialism that exists in our country, not only in medicine but everything else, and increase the number of accredited positions in primary care to accommodate this demand, I think, for a greater primary care capacity. So, Gail, tell me where I've gone wrong here.
This economist is going to turn to my physician experts to my left. Thank you.
Well, I don't think it's programmed anywhere into the transformation fund that there's a specific goal along the lines that you just stated. In addition, the committee did discuss the potential role of the accrediting agency in regulating the number of slots in different positions, in different specialties, and decided fairly quickly that that wasn't practical because of antitrust concerns or appropriate. So the accreditation agency is not being asked to do that. There will be other levers, some of which we've discussed earlier, that will probably come into play to try and ensure that we have the right mix of specialties going forward. Deb, you?
Yeah, I think it would not be correct to assume that we have thought that the transformation fund would be looking at more primary care spots. It would be looking at possible new positions where geographically there are needs for certain specialties. So there are geographic parts of this country where there is great needs for psychiatrists. There are geographic areas of this country where there are great needs for general surgeons. There are certainly geographic parts of this country where there are great need for primary care providers. We hope that the Policy Council will be looking at those distribution, specialty distribution disparities and using the Transformation Fund to create new programs to address some of those. And we feel that without the additional funding of those positions, it's very difficult to achieve those geographic smoothing out, if you will. But it's not only primary care. A lot of it is primary care, but not only.
But also, right now, as I understand, the more serious constraining factor in getting primary care physicians are not primary care residencies, but rather the interest of medical students in going in this direction. So while there may be some additional primary care programs that would develop if they saw the money out there, I think this is more of a demand-driven problem on the part of medical students who need to want to go that direction to the extent we think there may be a shortage, and the supply constraints are not nearly so much. And again, we've recognized all along that what we're saying for GME is maybe necessary, but in no way sufficient in order to right some of the distributional problems that the country faces. It's going to require reviewing the way that physicians are compensated and who's compensated, how much by specialty, and looking at potentially selective loan forgiveness programs given the amount of debt that physicians can get into. So it could be some additional primary care residency programs will be needed. My sense is that's not the major constraint. That's likely to be with us in the future.
Ed, do you have a comment?
I was just going to say I would agree with the earlier comments that it may not be just primary care. And I think your concern about the pressure on expansion, I guess I'm encouraged by the growth in the teaching health centers over the last several years, which many of them were new programs, and it's clear that it is possible, particularly when you expand beyond hospitals, to start new primary care programs.
Okay, last question. Brief, please.
Okay. Hi, my name is Kristen O'Brien. I'm with the American Medical Association. I'm going back to one of the principles that you discussed earlier about stability. And I know that we haven't figured out what a performance-based program would look like, but how would you reconcile the stability in funding that you all said was, very important with a performance-based program? And did the committee think there should be any sort of limits on how much funding is at risk in a performance-based program?
Well, stability does not mean you're entitled to the same money forever. This is certainly a principle that Medicare has been moving to in hospital value-based purchasing and in the home care and nursing home, and will be adopting in terms of the value modifier, and maybe moving even further with regard to some of the physician payment reform proposals. It is always a blend of a base amount payment and then potentially initially a performance-based add-on. Our assumption is that we won't jump full-blown from where we are now to 100% performance-based. At least Medicare has never done that. If at most tiptoes into these performance-based measures, if I have a fear, it'll be too slowly a tiptoeing rather than jumping in full-blown.
So I want to thank everybody for their participation. I want to thank my panel, Deb and Deb, on behalf of the whole committee, and Gail and in absentia Don Berwick for their incredible leadership and thoughtfulness and what I think is one of the most important reports the IOM has produced in many years. I want to thank Ed and Malcolm for going on the line, having just read the report and giving us some very thoughtful comments to put it in perspective. And I want to encourage all of you to read the report in detail. It is complex. It needs time to think about the principles that drive it, to think about what our goal is as an educational system, and to carry this discussion on. This is going to be something that's going to take time to solve. It took us almost 100 years to evolve the system we have in more than 50 years, its present funding structure. It can't be changed overnight. It can only be done thoughtfully with everybody's engagement to proceed in the right way in the interest of the public. So thank you for starting that process here. I look forward to more conversations to come.